Evening. Jim Salwitz here with the Medical Staff Quarterly for September 10th, 2020. I hope you are happy and well, and we start a lovely evening together. You know, this is the first pre-recorded full video Medical Staff Quarterly we've ever had. I hope you enjoy this format. Me personally, I'm alone out here in a room. There's nobody else and there's no food. So I have mixed feelings about this. No one's going to interrupt me, but on the other hand, I enjoy your company. But hopefully this works for all of us today. So we move out of the active COVID into the chronic COVID era, hopefully not going to see any major surges going forward, hoping to keep everybody safe. And as you all know, the hospital is in full swing, with capacities well above 90% level. And we're taking care of patients and community as we're supposed to. We're ready for COVID, if it spins back up, but we're doing our job. So we have for you an agenda tonight which focuses on the changes going forward. As all of you know, we've spent the last few years putting pieces on the playing field board. We've merged the large system. We have Rutgers. We're now building the new cancer hospital. We're expanding the surgical suites. We have all sorts of connections with the community and with the medical school. So many pieces coming together, hopefully seeing the St. Peter's piece adding to this going forward. We've assembled a lot of other pieces. And now is the time as are we going to bring them together in a whole. And a key part of that, will be connecting this all on a single database, which is the EPIC database. And so we felt it was time that you had an opportunity to hear about the EPIC project, understand what that future looks like, how we're going to be involved, what the demands it will make on us, and the opportunities. And so we've committed this evening tonight, to that focus. And I think you'll find this to be a fascinating opportunity. Before we begin that, a couple of comments I just wanted to make. First of all, I want to honor a couple people. All of you know Dr. Michael Solomon. Dr. Solomon is a urologist in our community and practice for many years and has done a tremendous job as a practicing clinician. But he also served the role for several decades as chair of the bioethics committee here. And he has done an incredible job, not only just keeping that committee together and the hard work, but in leading us, setting a tone, showing a certain maturity and understanding of ethics and of professionalism, and has been a tremendous teacher, I know to me, but to many of you. And Mike is now stepping down from that role. He's moving to join his family in Texas, so we wish him well. But thank you, Mike, for everything you've done, for all the lives you've touched, how you've taught each of us, and for the remarkable job going forward. I would like to recognize Dr. Len Lee, Dr. Stan Truskin, and Dr. Keith Lewis for their leadership in bringing the surgical suite together, not only because we're doing the construction and adding anesthesia and building, but how core that is now and making that as a core professional level surgical suite as we build it, as we grow and lead the system in that area. And tremendous good work in that area, and I think that needs to be recognized. And then, importantly, when you talk about transitions, there is our CEO and president and friend, Mr. John Gantner. John joined us 3.5 years ago at a critical time in transition. His deep love for this place, his respect for each human being, whether they're a patient, whether they're a staff, whether they're the individual nurse, doctor, and his love for the academic vision is well felt and understood by each of us. John has changed this place while he's been here. He has moved us through a critical time. And this institution will always be better, will always be special, in part because of the key decisions that John made in transitioning us through this time. And we will miss him. We thank him for what he's done, and we wish him well going forward. This is the quarterly meeting of the medical staff, the third meeting of the year, which means the fourth quarterly will go in December, which means elections for Medical Executive Committee. And there's two observations around that. One is it will be my last quarter serving as medical staff president, and I will step down as of January 1st. These are term limited, so after 6 years I'll be completing my term. I'll spending the next 3-4 months making sure the transition to the next president goes very well, closing out certain projects and moving forward. And if there are things I can help with in that time period, please don't hesitate to reach out. More importantly, it means that there are roles to be filled, and if you're interested in running for Medical Executive Committee, this is a really interesting and complicated time. You think about all the things that are going to come together in the next few years: changes in leadership, changes in structure, changes in affiliation, expansion of the academic mission. You want to be involved, this is the time to run. And so don't forget that those election opportunities will become available in December. You have to get your ballot in by mid-November. Please don't hesitate to reach out to medical staff office if you're interested in running. This is truly important time. And now I have the honor of introducing and welcoming the Chief Medical Officer of the RWJBarnabas system, Dr. Jack Bonamo.
Thank you, Dr. Salwitz. It's a pleasure to be invited to speak to members of the faculty during the quarterly meeting of your medical staff. And this is a topic that I'm very excited to talk about. And I won't say much because the two experts, Dr. Rob Adamson and Jordan Ruch, will be with you shortly to really detail that which we've done. But I will say that as we go through our hot wash post-pandemic and look at things that we could have done better, should have done better, maybe we could have had better communication, better keeping of statistics. Almost everything we do, we talk about, we say, but when we have EPIC, that will be different. When we have EPIC, that will be different. And it is so great to be able to have a solution that is coming our way that really will take care of so many of the issues that we wish we could do smarter, faster, quicker, in a more aligned fashion. And EPIC is going to do that for us. So pandemic, notwithstanding a super difficult time, whether we have a little bit of resurgence or not, does not matter. We still need EPIC to take us to that next place. It is very exciting. It is around the corner. We did not slow up. You're going to hear about some of the things we did to stay on track and to even be perhaps slightly ahead of where we thought we'd be at this point. So I am extraordinarily excited. We are blessed in having two great leaders, Rob Adamson and Jordan on the IT side, really bringing this project forward. So without further ado, we'll let those folks really explain exactly what it is that we are doing that's going to get us there on time and to a much better place than we are currently in.
And now, the key moments of the evening, and I think you'll really enjoy this. We have an EPIC conversation. As you know, the system committed several years ago to converting everywhere to the EPIC platform, and we're now moving forward with that. And it's critical that people understand what is happening and understand their role and how their lives are going to be improved, how lives are going to be changed, and where their lives are going to be challenged. I'm very excited to have with us Rob Adamson. Rob is the operational lead for the project throughout the system, and Jordan Ruch, who is the IT lead for the project throughout the system. I understand that they've both had an extended vacation. Rob, I believe you went to Cape May for one day.
One day.
And
in a row.
And you're fully rested. So And Jordan, I understand you went back in your backyard and repaired your deck.
Yeah, very relaxing.
Very relaxing. So they're set. They're all recovered from COVID and fully ready to go. So we are thrilled to have them both here to talk to us. So welcome, gentlemen.
Thank you.
So, real quick and obvious question. COVID hit. Everybody is pulled in every which way and direction. But I don't think you guys closed down. So you want to walk through those decisions and
Yeah.
what you did?
Yeah, sure. So for those who don't remember, the project was actually launched January of this year, if you can just think that far back to January. At that point, we had a simultaneous event where we launched the project. Between January and March, what we needed to do is come up with the decision-making bodies of how are we going to make these decisions, how are we going to build the system. And the way we did it essentially was we wanted to ensure a couple of things. One was that all the care models that we have in this health system were represented. And so essentially every one of our work groups, there are more than 60 work groups, and there are about another 7 more councils that overlay those work groups. And every one of them has to have a minimum 4 practice models represented: the academic medical center, community teaching, community, and then the medical group. And then depending on the discipline, or the disease state or the discipline, we also have behavioral health and pediatrics. And so what you'll see is we have those groups activated, and they got activated and really started to go in high gear somewhere around the end of February and the middle of March.
Oh, good timing.
Great timing. And so at that point, when COVID came in, clearly the health system, as well as this project, our first priority was COVID-19 site readiness. And so we decided, all right, what should we do? Should we actually pause this project? Should we just stop the project? What are we going to do? And so what we decided to do was, let's not just stop the project, because let's do this not emotionally, let's do this a little bit more logically. Is every single work group going to be affected the same exact way of COVID-19? And the answer, of course, was no. So as an example, if the respiratory work group and the emergency physician work group clearly were not going to be available to help us with EPIC. On the other hand, the finance group was very available to help us with EPIC, so we could still move forward with the finance group. Many parts of the nursing group were still available, so we went ahead and did that. The cardiology groups were all active during COVID-19. The infectious disease doctors, not so much. So when we looked at this, we saw that about 1/3 of our work groups actually needed to be paused, but 2/3 of them did not need to be paused. So we went from, instead of a full stop, to what we refer to as the strategic pause. We strategically paused parts of this project such that we knew we could always reconfigure our work from the different build phases. So if you're in build wave 0, 1, 2, 3, and 4, we could do some things in 3 and 4 that are independent of decisions, just some general scaling things. We all know what the floors are, and we can put in the different floors in the different places in a hospital. We don't need a decision on that. We know what those are. So we reconfigured our work so that we always had things to do while people were being site ready in COVID. So as an example, we had 24 of our nurses, because we have nurses on our team, actually we redeployed them back to their host hospital.
Oh, wow.
So that they can help with site readiness, because we did not want any stone unturned, because that was always going to be our priority, so we did that. So when the work groups were paused, we decided at that point, let's keep marching forward. The other thing that people forget is now we have to take all the people who were centrally working on this project in the Oceanport area and send them home to work remotely. So there were estimates by the EPIC Corporation that we would lose approximately about 1/3 of our efficiency. It turns out that after we did that, it turns out we're actually 43% more efficient when we went remote than when we were on site.
Which is what I think a lot of management literature has said for a long time, that remote work works.
It does.
You know, that people do perform, and of course, they're maybe happier. In this case, they're safer, which is not
Correct.
a minor piece of happiness.
Correct.
So that actually turns out to be a very interesting and efficient model, probably something we think about even in the future.
It's funny you say that, because Jordan and I just had a meeting, I guess it was last week, on space planning, where we're going to designate people in really 3 categories. Fully remote, but keeping in mind that sounds nice, but if you don't have the work environment at home, 3 kids sharing one room with your husband or your wife, and then can't hear anything, so it sounds nice, but not everybody has the same levels to do that. Then there'll people will be hybrid. Sometimes they'll be in the office, sometimes they'll be home, and then some people say, I don't want to be home, please, I want an office. And so we're actually doing that in the Oceanport area so that we can see all the lessons we learned through those efficiencies. One of the things in the medical group, as an example, that we need to do strategically is the migration to telehealth. And one of the challenges we actually have was, how are we going to market telehealth? How are we going to get telehealth to the next level? Well, COVID-19 took care of the marketing. COVID-19 took care of telehealth. Basically what it did is it said, that's the only way we can do this. You'll have people who are not going to do it any other way but that way. Others who want to go out in the back, and then some will do something in the middle. So there was a lot of lessons learned during COVID-19, but I think the most important thing was, the reason you haven't heard about EPIC is not because we weren't doing anything. It was our first priority was COVID-19 and site readiness. So we were intentionally silent so that the only message you heard was COVID-19. Today, we're really happy and thrilled to be sharing as we start to come to a stable period in COVID-19 to now let's re-energize the conversation, which is what we want to do today, and to tell you about the timeline, the exciting things. Jordan's going to share with you some statistics, but it may be very interesting to know that we're practically on the core side of the build, practically done at this point. We had a target of July 31st to be 95% done. They told us prior to COVID-19 it was going to be very difficult to do that because of the size and the scope of this project. With COVID-19 was darn near impossible, and that's a testament to all of the people in the work groups, the councils, all of the subject matter experts really making themselves available to make decisions, and then of course the remarkable team that I get a chance to be a part of.
I want to lose a piece that you didn't mention, because from our earlier conversation, you mentioned that the teams, the 62 teams, are all composed of multiple different components that you insisted to be there. That's not typical of an EPIC rollout, is it?
Right, so that's a great point. So that models that I talked about, those 4 core models and then the 2 optional models of academic medical center, community teaching, community, the medical group practice, and then, depending on what we're speaking about, behavioral health and pediatrics. We've come to since find out that EPIC actually now recommends that to all new customers that are very large integrated delivery networks, because it was one of the things they struggled with. How do we organize people on work groups so that they actually represent what goes on in the integrated delivery network? So what was happening is organically you would have one group through the leadership of that particular work group saying, hey, let's have everybody multidisciplinary come in. Then you'd have another group that just actually invited people they knew, and that usually was uni-focused wherever their practice site was. What we wanted to do is, rather than have an organic process, we wanted something very intentional and very thoughtful so that everybody shares in the development of the electronic health record. We have a guiding principle that says we don't want to build this for any one discipline, any one practice, any one facility. It's got to be for all of us, because a universal electronic health record needs to work universally.
It's interesting. It's almost a cultural statement, and in the sense of building, you building much more than buying an iPhone changes your culture. I mean, we build culture together, both of the process that we build it and then what we create afterwards. It's and it's also interesting because, again, we were talking earlier, this is the size of this project, the size of this rollout at the same time, is just immense, bigger than in most projects, and everybody will be on it.
Yeah, so this is one of the largest projects in the history of the health system, both financially, but more importantly, scope. And so when we were talking off camera before, but one of the reasons people ask me, why did you want to take this job and why did you want to be a part of this project?
Did you just weren't out of the room at the time that they voted on this? No?
Yeah, they just said, "Are you voluntold?" And they asked me, and I said, it's to give our patients a voice. All of you as clinicians who I'm speaking to right now have all had this patient where you ask them, what was the doctor's name you saw? I don't know. What was the procedure they did on you? I don't know. Now, what we do is we ask for the patient's records, and sometimes they fax them to you. Sometimes they overnight them to you. If you're lucky, you get them on a thumb drive, perhaps. With EPIC, what's nice is that after we're fully installed, basically almost about 70 to 75% of the state will all be on the same electronic health record.
And by that, you just don't mean RWJBarnabas. You mean the state of New Jersey.
That's correct. Along with other places in Pennsylvania and Philadelphia, as well as New York City. And why is that important? Because one of the great functionalities of EPIC, which we don't currently have, is a universal health record means that if you're in a physician's office practice or you're in the hospital, you're still in the same electronic health record. You're not on a separate version of that. The other thing that's wonderful is, let's assume that I'm your patient and I go to one of those other health systems in New Jersey, and now you're seeing me. If you ask me, would you mind if I go out to EPIC all of EPIC, the entire world, and query my records, and I say, yes, that's fine. You can do that. It's going to grab any record that exists in an EPIC platform, and it'll come into our EPIC version and make a complete medical record, all the things you're about to do with me, and anything that's been done historically at the click of a button. Now, that's a lot different than what we practice now. So if you think of something just that simple, it's giving the patient a voice. It's giving you all the information that you usually never get. So we repeat a test because we didn't know you had that already. I send these out, and now we have a second pathology that comes back because I didn't know you had a first pathology, and you get the idea. So if you think of the redundancies of waste, inefficiency, the things that you're asking your patient to do for the third time. How many times have your patient said, don't you people talk to one another? And now we will be able to, because we'll have a universal EHR.
Very exciting.
One of the other keys, I think, to that kind of universal strategy, Rob, and I know it's one of our guiding principles, but using the foundation system as kind of a starting place for us really gives us the ability to share not only among all of our own institutions, but outside our walls. And the more as a configuration we stick to that foundation build, the easier it's going to be for us to share information to the outside, and the easier it will be for us to bring information in. So I think it's a key element for people to understand, how that foundation system element comes into our equation so heavily.
And Jordan brings up a great point. So EPIC, if you were installing EPIC 10 years ago, you would get an empty shell. You would start to build what you think makes sense for all of you. But if I talk to a colleague who installed it, let's say across the river, I would not have the ability to figure out what's working in your facility so well. So what they did is they said, hey, listen, if Johns Hopkins, the Cleveland Clinic, etc., are all using this system, they have best practices, workflows, order sets, all of those things have been built already. Why would, and what EPIC noticed is we're all basically trying to reconfigure the system the same way, so why not start from what they call the foundation system? Let's take all the best practices, those things that have been shown to be highly reproducible, very successful, and someone says, well, I'm using the Cleveland Clinic's X. Well, we'll all be using it because it's part of the foundation system. And so as new members, we're going to come up with best practices. We put things into the foundation system.
So I guess that's the important question. So the obvious thing, as a clinician, I'm hearing this, and I'm going, yeah, but I don't like to practice medicine from the left. I like to practice medicine from the right. Yes. I don't care what the Cleveland Clinic says.
Correct.
So, how, understanding the value of what you just said, I'm still like that. How are we going to work with our clinicians to help them navigate? Because I think, frankly, every time you change IT platforms of any sort, that may be among the most painful things that you have to navigate. How do we get through that process?
So it's a great question, and in fact, it's the fundamental things that our work groups and our councils work on. What they do is we don't accept the foundation and say, okay, we've accepted it. Thank you very much. Take care. That's not what we're doing. What we do is we take the foundation system as a place to start, and we say, does this work for our workflow? The answer is yes or no. Okay, if it's no, do we need to change to this because is it a better workflow? And in many cases, what we're finding, it's the thing we all knew we needed to do. No one just got around to doing it. And then there are instances where our workflow is different and we configure it different. But what foundation is it's not something we accepted 100% of the time. The work group and the councils, they spend most of their time validating that makes sense for us, or do we need to do something different? So that's a lot of what the work is validating that foundation system. All the foundation does, honestly, is accelerates acceptance, and it accelerates consensus quicker because many of it is based on what we already do now, or things we know we would want to do but not sure how we would organize around that, because just because we decide to do something, that doesn't mean all the policies have been harmonized to do the new workflow and things like that. So really, when you look at the foundation system, it serves at the very central part of the validation of does this make sense for us or not, and that's what the work groups and councils do.
And as we start, I think as we start to get into the training phase of the project, some of the features that differentiate EPIC from Allscripts and Centricity in particular are going to be highlighted, because there's a lot of features around personalization that really weren't available to us from an IT perspective in Centricity and in Allscripts, but are available and part of the core of EPIC. So as everyone starts to get trained and familiar with those personalization options, I think while it may seem, just hearing the word foundation that we talk about, that's kind of locking you into a workflow, it's actually not. What it gives us is the ability, though, to share a lot more easily, and it gives us a really good starting place to make it our own.
Yeah, and I think one of the analogies we use, Jordan, all the time is, let's assume we're in this room right here. You as a clinician, let's say this is EPIC, this room. You can configure this room, what's in here right now, you can configure that pretty much any way you want to adopt your workflow. What we usually do is we limit what you can bring in to the room when you're configuring it. So as you would expect, the EPIC system has many, many, many things, so you can configure it many different ways and personalize it. So think of it as this room. If you want to put the tables this way, that's completely fine. If I do this first and that third, that's completely fine. And that's why we go through this validation to make sure that the inventory of things in there for you to configure are the right things. And that's what the work groups and those councils are doing just as we speak. We're actually just coming out of validation now. We're about 95% done.
Wow, truly impressive. All right, so I hear what we're moving towards. Where are we at now as actual process? So as of this September, where are we moving for now?
We have about 95% of the overall core build of the system completed as of a few weeks ago. So it's an amazingly exciting time for us in the project. There's more build to be done, and there's more conversations to be had and more standardization, hopefully, that we'll be able to enjoy together. But I think right now we're at about 95% of the core build of the project complete. So if you think about the themes of work that constitute our project overall, we've been focused a lot up to this point on those decisions and that consensus building and that operational playbook part of the work. And then obviously we're taking those and we're applying analysts behind the keyboard doing the actual configuration and building of the system that we'll all get to use shortly. As we move into the next phase of the project, so if you think about us on a timeline, we're moving out of that configuration phase and we're moving into the user and system readiness phase. What that means is there's going to be a lot more time that we spend doing audits of the build that's already happened. So we actually invite EPIC and we invite others to look at the build and configuration we've done so far. Knowing what they know about implementing this system across the country, they help us validate that some of those build assumptions are solid. And then they'll actually question us on build decisions that were made as a cross-check to make sure that everything looks right from their perspective. The other thing that we shift into as we get into this user and system readiness part of the project is testing. So the approach to testing is fundamentally different from anything we've ever done before as a health system. So there's almost a full year of testing that the system goes through before it gets presented to an end user. And that's just from a software perspective. From a hardware perspective, every device that a clinician is going to use to get into EPIC when we go live will be tested before we go live in a process called technical dress rehearsal that happens about a month before we go live. IT is actually going to go to every workstation, make sure it can log in, make sure it's operating correctly, make sure it can print correctly, and that's going to be done at every activation. So that testing part of this next phase in our project is really critical. When we talk about our overall activation timeline, I think, Rob, you want to share some of our recent looks at the timeline?
Yeah, sure. So, and Jordan, I'll just continue on prior to that on one extra point, and that is when training is going to start. And so training right now, we are recruiting what's called the specialist training specialist. What that essentially means is rather than being trained by someone who's just really proficient in the EPIC system, what we're doing is we want to start recruiting, and anyone who wants to be a part of the training, please just reach out to myself or Jordan, so that if you're a neurologist, it probably means more having a neurologist show you the system, a surgeon, oncologist, whatever the case may be, so a specialist training specialist. We're in the process right now, October through January, where we're going to be recruiting right now through October, end of October, and then start training those people to ultimately start training in January of 2021. And the reason we're training in 2021 is our first activation wave is very exciting, is April 30th, and who's going live? So April 30th, it's Robert Wood Johnson Physician Enterprise. It's an ambulatory activation, so it's Robert Wood Johnson PE. It's Rutgers Medical School. It's going to be the CI&J physicians. They're going to be activated on the ambulatory EPIC platform. And then lastly, our Federal Health Qualified Center, Chandler Center, will also be activated. And that's going to be on April 30th. Then what we tried to do is essentially we want to use about a 6-month runway between the first activation and the next. And the reason we do that is, one, you want to activate them, then you want to make sure you stabilize them. And then as you're stabilizing people who are activating, you start shifting your focus to make sure you're ready for the next activation, which is October of 2021, where the Barnabas Health Medical Group becomes activated. And then also we have Somerset, which is our first acute care facility being activated. So that's actually very, very exciting. And then Wave 3 is probably very, very germane to you, because Wave 3 is where we finally will activate Robert Wood Johnson University Hospital. CI&J, the infusion center, the entire center goes up on EPIC, as does Hamilton and does Rahway. And so that's going to be in Wave 3, and that's going to be in late March of 2022. Then from there, we are still talking in quarters and part of the year, but in general, those first 3 waves have been identified. It's really, really exciting, because then once we're done, by the time we get to Robert Wood Johnson University Hospital, your entire medical group will be on one platform. So you'll have the ability to refer in very quickly once you're activated, the entire medical group, as well as the University Hospital. By March of 2022, you'll all be on one platform to refer in and out. So if you think of CI&J as an example, one of the great things is once all of them are on the medical group platform, you'll have the ability to refer right into CI&J directly from every single practitioner in the medical group. That's at Rutgers, RWJPE, BHMG. Once the combined medical group's on one platform, you'll be able to refer in 1, 2, 3, rather than the paper process and the things that happen nowadays. So it's very exciting.
And training for each of these waves, and given the COVID world, I'm not sure if you want to rethink that terminology, but we'll let it go for the moment. Each of these will start at each of the institutions, individual training, a month or 2 or so before they go live. That's the basic thinking, or?
Yeah, generally you start. So generally we'll start in about 3 to 3.5 months prior to a go live, just because we're going to do 2 things. We can't just have you in a very, very large room and one lead instructor in the front. So we'll be doing virtual training, and essentially what virtual training, or the definition of virtual training, is your instructor may be in a conference room, you may be either in a cubicle in the Oceanport area, you might be in the hospital in a socially distant way in a classroom, but we'll be able to utilize the size of the health system virtually to do virtual training, and we have to plan for that because we don't know what the world's going to be once we get to an activation date. So if in April 30th we can do things in large mass, we can rethink that strategy, but we're starting in a virtual only training mode, and then we can work our way backwards.
Well, we've learned that the virtual mode is very good for a lot of people anyway, and it gives the kind of flexibility, and as well as safety. So that may turn out to be the best thing anyway.
We can, and we have a vendor where we can do whiteboards virtually. I can take you in a private breakout room to say you would like one-on-one instruction. We can do all of those things virtually. virtually. So we'll have the platform as best we can to provide you that same personalization you would get if somebody was in a classroom with their teacher.
And then long run, what's the long-term waves for finishing system-wide implementation?
Yeah, the last wave is going to be, it's either going to be the fourth quarter of 2023, or it might be possibly early first quarter 2024. And that last one is Children's Specialized Hospital.
Okay.
They're at the very end of the activation strategy. The one thing that's very exciting, though, is what does the forever team look like? Obviously, when we look at the build, it's always we have all these assets, we have all these people training, so on and so forth, and then we activate and it sort of dissipates and you go to a scaled down model. And that's not what we're doing here. So as an example, we're going to have still 25 full-time credentialed trainers only specific for updating your curricula, making sure you actually have people who are training throughout the system, and then optimization. So one of the things we haven't done well as a health system in our EHRs is what I would call a universal optimization strategy. Part of that, candidly, is because how do you optimize 3 different EHRs that have 3 different functionalities and limitations? So now that having a universal EHR, we finally have the ability to have a long-term optimization strategy, which we've never enjoyed before. So when we get finished with the activation, it's not like the team goes away. It'll scale back a bit, obviously, because implementation, you don't need an implementer if you're implemented, but you do need people to maintain, optimize, train, et cetera, and they've made a very robust investment in that team. It's not scaled down at all. It's several hundred people, actually.
Wow. And of course, we'll need that addition to those people as the system expands.
Yes.
Status post-merger, implementation and et cetera, that, they're going forward there. So
that's right.
Challenging time.
That's right.
So here's a fantasy question. So how does artificial intelligence play into the future use of the EPIC platform?
I think that's a great question. So the easy answer is that going
There's an easy answer for artificial intelligence? Okay,
well,
good.
maybe let me take 2. So I think the first thing that comes to mind is that being on a single platform, not only with all of the amazing providers within our own health system, but being on the same platform as some of the other leading institutions in our country gives us a natural benefit to research that we've never really had before. So one of the ways that I would answer that question is to look at the marketplace that is now available to us based on being live in EPIC. So it's not just that we can have a template for a chest pain order set. It's that we can look at a study that was done at another leading academic medical center and actually take the build into our system. We can see what they did and how it impacted sepsis and what their program looked like and what the forms look like and what the workflows were. And we can actually take that into our EMR as a starting point. So we can really learn from the best practice that's already been implemented. And I think from if you think about taking the power of many and consolidating that down and making that into something that we can digest into our EMR, that's really where the power is. So, from an AI perspective, the system does have the capability to do natural language processing, to do suggested problem lists, to help us with some of the pain points that we have with dictation go away when we go to EPIC. So I think there's a lot of exciting things to come.
I thought one of the interesting successes, but also challenges with the COVID event, was everyone trying to keep up with that day's understanding of the technology, of the disease, of the response. And even in a relatively communicating system such as ours, there was differences in different places. When you think about not just our system, but tens of millions of patients and their doctors and institutions on a system that can share best practices in real time.
It's huge. And you bring up a really good point, because I have personal experience because I worked on the teams who were deploying the order sets to Cerner and the order sets to Allscripts as part of our response. And I can tell you that in the EPIC marketplace that we were talking about a little bit earlier, the COVID package was available in April. And we would have been able to take that into our environment and use it in an instant.
In April, that's
it
very
wouldn't be,
early.
it wouldn't be a process that we have today, where it has to get built and implemented in all these separate EMRs. We really could have gone to that marketplace, taken that content, and made it available. So it's a huge differentiating factor for us.
And also I think, at least in my mind, in a big data AI world, this is a massive number of patients in real time that we can learn from, and evolve, evolve to give better care, and as we go forward.
The other thing I think Jordan brings up is that we've also made the decision to share our data. Obviously, it's blinded, etc., but to share it with the EPIC community. And so what that basically means is instead of looking at a data set of 1 million records, it gets populated into a data set of 25 million records all over the country. So if you're looking for, let's say, a fairly rare disease, you might see 7 of these in a year. You can actually put the criteria into EPIC as an outbound message, look at the entire population and say, oh, of 25 million people, I now have 375 people we found who could potentially benefit from a study. And as Jordan said, if we're looking for patients, you can preference it to say, if somebody comes to the emergency room with these criteria, we can flag it to say they are someone who could be in one of our studies, as opposed to what we do now, which is a little bit more catch as catch can. Here you can do something on the front end to make sure we design the mousetrap to find folks to recruit people. So as we migrate, our aspiration of being this clinical academic health system, and it's just unlocking the power of these two great organizations.
Absolutely.
Well, the one that's going to enable us to do that will be EPIC. It's really a differentiator.
One of the other really important considerations that's game-changing for us is a product called Slicer Dicer. It comes along with EPIC. We don't have to pay anything extra for it. But when we talk about the partnership between Rutgers and RWJBarnabas, this is an area that is really exciting, because when we have research requests or when we have data requests, there is, because of all the different EMRs, it's very complicated for us to get good data a lot of times. And the Slicer Dicer product is actually going to put the ability to generate data. Some of it, it's configurable how we use the tool, but we're going to be able to give providers the ability to follow hunches and do some of that data manipulation right in the front end of the system. So it's not going to be an IT ticket to do a data request. If you want to see all the patients that meet this criteria, how this drug impacted that patient's outcome, that's actually something available to you in the front end EMR. So that's a fundamental difference from where we are today.
So final question, gentlemen. Going forward, what keeps the two of you up at night?
So I would say the thing that keeps me up at night, honestly, is the resiliency of the people involved in building this. So I would say you have the people on the build team who are working very, very long hours. You also have your subject matter experts, the people in our health system in the work groups. They have a day job, and they have to take care of our patients, yet they're being asked many, many hours during the week to sacrifice his or her time in order to go on our committees, to do all this extra review, and at the same time take care of our patients and the mission. So I always worry about how that balance is going to look at. The project, of course, there's many things on the project I could worry about, but for those of you who I'm speaking to right now, many of you may be on some of these work groups, and I understand the commitment, and it's a heartfelt thanks for being a member of those committees and those work groups. I worry about their resiliency and making sure coming out of COVID, trying to be part of the EPIC team, trying to do all this build, it's a lot to ask for, and that's kind of the things I worry about.
Jordan?
So what keeps me up at night is we've spent a lot of time at this point building and configuring the system, And we're at a point where we're ready to have a lot more hands in the system helping us test it. We're, as Rob mentioned, entering a phase of training. And I know we are at a vulnerable point because everyone is working so hard. We're dealing with the crisis. We don't know what the future is going to bring. So that's what keeps me up at night. I think that we've been shown that this is the right move for us as a health system right now to get on this standardized platform. The timing is what it is. And my fear is that we have the capacity to implement the system without impacting patient care, because that's our number one priority. Our number one priority is getting to a point where we have a single platform where we can make enhancements to the lives of our providers and the lives of our patients. That's our number one goal. So doing that effectively with everything changing around us is what keeps me up at night.
Well, I can appreciate both your concerns, which reflect part of the same piece, and then it comes down to people being involved and commitment. I think maybe an exciting answer to that is that this is something really exciting, really powerful that we need people to be involved in, but therefore people can help change and can help build and help grow. So at a time when we're not completely sure where our next steps are, we know where our next steps are. We know where to head.
That's right.
And this is going to be incredibly important, and it's very exciting for what it can achieve. Both practicing medicine for our patients in general, for the next major health crisis, which will come along in the future at some time. And this is the time, of us to build that and for people to reach out, and understanding how tough it has been. This is an exciting opportunity for all of us to rebuild ourselves as well as the system at the same time. So,
Thank you.
So, Rob, Jordan, thank you very much for your very hard work. Thank you very much for being here, with us. And, we look forward to future communication, staying in contact, and building together. So thank you.
Sounds good. Thank you.
Thank you.
So I hope you enjoyed that as much as me and learned as much as I did. Obviously, a lot still to learn, a lot of interaction, a lot of conversation, but really an important movement and coming together for our system as we go forward. So thank you all for being here this evening. Treat each other nice, work the problem, learn from each other, and we are RWJUH strong.